Here is a structured summary of Chapter 3, Mouth Preparation, based on the provided text pages. 1. Introduction and Overview. Goal of mouth preparation. The oral tissues must be in a state of optimum health before commencing complete denture fabrication to achieve maximum comfort, function, and retention. Sequelae of wearing complete dentures. Long-term denture wearing can lead to adverse mucosal and bony changes, direct and indirect sequelae. 2. Direct sequelae, mucosal reactions. A. Denture stomatitis, denture-induced stomatitis, chronic atrophic candidiasis. Definition: pathological reaction of the denture-bearing mucosa. Newton's classification. Type 1, localized simple inflammation or pinpoint hypemia, often trauma-induced. Type 2, erythematous or generalized simple type involving a part or the entire denture-covered mucosa, plaque-associated. Type 3, granular type, inflammatory papillary hyperplasia, commonly involving the central part of the hard palate and alveolar ridges. Etiology: presence of dentures, denture plaque, trauma, and Candida albicans infection. Predisposing factors: systemic, old age, diabetes mellitus, nutritional deficiencies, iron, folate, B-12, malignancies, immunosuppression, steroid use. Local: dentures, xerostomia, high carbohydrate diet, broad-spectrum antibiotics, smoking. Diagnosis: confirmed by mycelia, pseudohyphae on a direct smear or high colony counts, greater than 50 colonies. Prevention and management: oral and denture hygiene, clean dentures with soap after meals, massage mucosa with a soft toothbrush. Soak dentures overnight in 0.2% to 2% chlorhexidine or dilute sodium hypochlorite. Avoid hypochlorite if metal components are present. Polish tissue surface. Correction of ill-fitting dentures, trim, polish traumatic areas, reline with tissue conditioner. Antifungal therapy, topical nystatin, amphotericin B, miconazole, or clotrimazole, preferred over systemic ketoconazole, fluconazole. Continue for 4 weeks. Surgical treatment, indicated for type 3, papillary hyperplasia, via excision or cryosurgery to eliminate crypts. B. Denture irritation hyperplasia, Apellis fissuratum. Definition: tissue hyperplasia of the mucosa along denture borders due to trauma from ill-fitting dentures. Etiology: chronic injury from unstable dentures or thin, overextended denture flanges. Clinical features: single or multiple folds of hyperplastic tissue in the alveolar vestibule, often with deep fissures, ulceration. Management: surgical removal of the lesion followed by denture adjustment, relining, or replacement. C. Fibroepithelial polyp, leaf-like denture fibroma. Etiology: irritation or trauma of the maxillary denture foundation. Clinical features: flattened, pink, leaf-like mass attached to the palate by a pedicle, sits in a cupped depression. Management: surgical excision and denture relining or remake. D. Flabby ridge. Definition: mobile or extremely resilient alveolar ridge resulting from replacement of bone by soft fibrous tissue. Etiology: excessive load on the residual ridge caused by unstable occlusal forces, e.g., remaining natural anterior teeth opposing an edentulous maxilla. Management: surgical removal, if needed, though may reduce ridge height, vestibule depth. Special impression techniques designed to preserve soft tissues without distortion, detailed in Chapter 4. E. combination syndrome, Kelly, 1972. Definition: characteristic destructive changes occurring when an edentulous maxilla is opposed by natural mandibular anterior teeth. Key features: loss of bone from the anterior maxilla, replaced by flabby ridge. Overgrowth, hypertrophy of the tuberosities. Papillary hyperplasia of the hard palate mucosa. Extrusion of lower anterior natural teeth. Loss of alveolar bone and ridge height under posterior mandibular removable partial denture bases. Cause: inadequate posterior occlusion leading to anterior hyperfunction. F. Traumatic ulcers, sore spots. Etiology: overextended denture flanges or unbalanced occlusion, exacerbated by systemic factors like diabetes, xerostomia, or nutritional deficiencies. Clinical features: small, painful ulcers covered by a gray necrotic membrane with an inflammatory halo, appear 1 to 2 days after placement of new dentures. Management: relief of offending denture area, occlusion. Spontaneous healing occurs in a few days. Symptomatic relief with anesthetic gels. Note: any ulcer not healing after denture correction must be evaluated for malignancy. G. Burning mouth syndrome. Definition: burning pain in the tongue or oral mucosa with normal clinical, laboratory findings lasting at least 4 to 6 months. Clinical presentation: mucosa appears clinically healthy. Symptoms may be severe enough that dentures cannot be tolerated. Must be differentiated from mechanical denture irritation. H. Oral cancer. Chronic irritation from dentures has been associated with oral carcinoma. Heavy alcohol, tobacco use and low socioeconomic status serve as major predisposing factors. Regular 6-month recall examinations are recommended. Here is a structured summary continuing the content from the additional pages of Chapter 3, Mouth Preparation. 3. Direct and indirect sequelae, continued, a burning mouth syndrome, BMS, etiology, local factors, undue friction on mucosa, denture instability, prolonged masticatory muscle activity, parafunctional tongue habits, myofascial pain, oral candidiasis, or allergic reactions. Systemic factors, menopause, most common, vitamin B_12, iron deficiencies, xerostomia, diabetes, medication side effects, Parkinson's disease. Psychogenic factors, depression and anxiety. Clinical features, strong predilection for postmenopausal women. Symptoms often begin after new denture placement. Pain starts in the morning and increases through the day. Associated with xerostomia, altered taste, headaches, insomnia, and irritability. Management, thorough evaluation to correct local denture causes. Patient reassurance, counseling that condition is benign. Psychiatric referral when necessary. B. Gagging or retching. Mechanism, a normal defense mechanism to prevent foreign bodies from entering the trachea. Triggered by tactile stimulation of the soft palate, posterior tongue, or fauces. Can also be triggered by sight, taste, noise, or psychogenic factors. Etiology, overextended denture borders, posterior maxilla, distolingual mandible, unstable occlusion, increased vertical dimension of occlusion, VDO, restricted tongue space, GI disorders, alcoholism, or smoking. Management, identify and correct the specific underlying technical or physical cause. C. Residual ridge resorption, RRR, caused by disuse atrophy, excessive force from continuous denture wearing, and unstable occlusal conditions. D. Altered taste. Etiology, palatal coverage of taste buds, ill-fitting dentures restricting food choices, nutrition, poor oral, denture hygiene, debris accumulation, or olfactory, neurological deficits. Management, maintain oral, denture hygiene and correct denture defects. E. Altered speech. Temporary alterations, caused by denture base thickness, altered tongue position, or increased salivary flow, managed by reading aloud for practice. Persistent phonetic problems, caused by incorrect incisor position, altered palatal contour, occlusal plane, restricted tongue space, or improper posterior extension. Requires denture modification or remaking. F. Angular cheilitis, Perlesh, definition, multifactorial condition affecting the labial commissures. Etiology, loss of vertical dimension or worn dentures leading to deep skin folds that become macerated and infected, candidal or staphylococcal. Predisposing factors include iron, vitamin B deficiency, AIDS, diabetes, and neutropenia. Clinical features, deep, ulcerated fissures, cracks at the corners of the mouth covered by a superficial exudative crust. Fissures stop at the mucocutaneous junction. Management, restore VDO, eliminate primary cause, and prescribe antifungal, antibacterial agents for secondary infection. G. Galvanism, caused by dissimilar metals in the oral cavity producing electrochemical corrosion. May lead to BMS, oral lichen planus, or altered taste. H. Indirect sequelae, atrophy of masticatory muscles and nutritional deficiencies. Complete denture wearers show reduced bite force and reduced masticatory efficiency compared to patent dentition. Overdentures or implant-supported prostheses restore occlusal force and efficiency. Dietary counseling may be required for compromised elderly or chronically ill patients. 4. Mouth preparation procedures. Mouth preparation prior to prosthetic delivery involves 4 main steps. A. Elimination of infection. Treat carious teeth, periodontally compromised teeth, non-vital teeth, herpetic stomatitis, and denture stomatitis, candidiasis. B. Elimination of pathology. Surgical excision or treatment of cysts, tumors, and unattended jaw lesions. C. Conditioning of tissues. Allow deformed tissues to recover by leaving old dentures out or using soft tissue liners. D. Nutritional counseling. Ensure dietary adequacy for patients with compromised metabolic or masticatory function. 5. Pre-prosthetic surgery. Definition. Surgical procedures designed to facilitate fabrication or improve the prognosis of a prosthesis, GPT-8. Conditions preventing optimal prosthesis function, retained dentition, retained roots and unerupted teeth are generally removed, unless deeply embedded in bone, asymptomatic, and free of pathology. Soft tissue abnormalities, hypertrophic labial frenum, can interfere with peripheral seal, cause ulceration, or lead to denture midline fracture, treated via frenectomy. Hypertrophic lingual frenum causes tongue tie and speech impairment, treated via frenectomy. Prominent buccal frenum usually does not require surgery due to flaccid, compressible nature. Excess hyperplastic tissue, flabby tissue, inflammatory papillary hyperplasia, and apellus fissuratum require surgical excision. Bony abnormalities, irregular alveolar ridge, alveoloplasty, recontouring, smoothing, and shaping of alveolar bone following extractions or healing. Ridge undercuts, small anterior labial undercuts can be preserved, but bilateral undercuts or severe posterior undercuts require surgical reduction. Prominent mylohyoid ridge, sharp ridges covered by thin mucosa dislodge the denture and cause pain, require surgical recontouring with bone files and muscle detachment. Here is the detailed, structured summary continuing the remaining pages, pages 32 to 34, of Chapter 3, Mouth Preparation. Pre-prosthetic surgery, continued. Bony abnormalities, continued. 1. Maxillary tuberosity interference. Presentation. Pendulous tuberosities with undercuts encountered unilaterally or bilaterally. Effects. Interferes with intra-arch space, denture insertion, extension, and mandibular movements. Management. Requires surgical correction if it interferes with normal denture function. Bilateral undercuts require surgical recontouring at least unilaterally. Caution must be exercised because the maxillary sinus can expand into the tuberosity. Surgical reduction should be guided by radiographs. 2. Sharp, spiny residual ridges. Presentation. Knife-edged ridges that commonly occur in the lower anterior region due to rapid labial and lingual resorption. Effects. Hypermobile tissue covers the ridge and becomes trapped between the denture and sharp bone, causing severe soreness, discomfort, and denture instability. Types. Mayer described 3 types: sawtooth, razor-like, and discrete spiny projections. Surgical treatment involves recontouring of bone, reshaping soft tissues, and closure of epithelium with sutures. Non-surgical management, if surgery is contraindicated, selective pressure impressions to reduce pressure in the affected area. Reduction of the occlusal table with maximum denture base extension. Permanent resilient liners. 3. Tori and exostasis. General features: benign, slowly growing bony projections of maxilla or mandible. They reach maximum size by the 3rd decade and have an unknown etiology. Mucosa over tori is thin and easily abraded. Maxillary tori, torus palatinus, located at the midline of the hard palate. Smaller tori require relief on the denture base rather than removal. Indications for surgical removal: speech interference, disruption of the posterior palatal seal, denture instability due to fulcrum effect, or undercut tori that trap food debris. Mandibular tori, torus mandibularis, bony protuberances on the lingual aspect of the mandible, usually in the premolar area. Cause frequent mucosal irritation, sore spots, lack of border seal, and speech interference. Management. All mandibular tori need to be surgically removed. Enlargement of denture-bearing areas. 4. Vestibuloplasty. Definition. A surgical procedure designed to restore alveolar ridge height by lowering muscle attachments on buccal, labial, and lingual aspects of the jaws, GPT-8. Purposes: obtain greater denture extension and reposition muscle attachments to provide better support. Techniques: mucosal advancement. Subepithelial connective tissue is dissected and repositioned apically using a surgical stent. Used mostly in the maxilla, carries a potential for relapse. Secondary epithelialization. Apically repositioned flap is sutured to periosteum at the desired depth and allowed to heal by secondary intention. Requires overcorrection due to a 50% relapse rate. Epithelial graft vestibuloplasty. A full-thickness mucoperiosteal flap is raised and covered with a skin or oral mucosa graft, healing by primary intention. This is the most successful vestibuloplasty method. 5. Ridge augmentation. Indication: add strength and height, contour to an extremely deficient mandible or maxilla using bone grafts. Graft options: autogenous grafts, harvested from iliac crest or rib, biologically ideal but require extensive donor site surgery. Alloplastic materials, e.g., hydroxyapatite, avoids donor site surgery but presents resorption issues and unencouraging overall predictable recovery. Clinical note: bone grafting combined solely with conventional complete dentures is generally not recommended due to cost, success rate, and surgical morbidity, especially in elderly patients. Modern approaches combine bone grafts with osseointegrated implants with promising results. Chapter Summary. Key takeaways. Examination of hard and soft oral tissues determines the specific pre-prosthetic mouth preparation required before complete denture fabrication. Mouth preparation is equally essential for existing denture wearers suffering from tissue abuse. Existing denture wearers must abstain from wearing old dentures for at least 48 hours before primary impression procedures commence.